This table here summarizes the normal ventilation values that you would measure sort of on average. The total pulmonary ventilation is a number that you should know. It's on average about 6 liters per minute, and we calculated by multiplying the respiratory rate of about 12 breaths per minute or so times the tidal volume of about half a liter, 0.5. So that would be 6 liters per minute. The total alveolar ventilation is calculated by multiplying the respiratory rate times a tidal volume that has been corrected for the anatomical dead space. So you're subtracting 150 milliliters from the 500 milliliters of tidal volume, then you have 350 milliliters left, and times 12, that adds up to, or multiplies out to 4.2 liters per minute. Maximal voluntary ventilation is somewhere between 125 to 170 liters per minute. So that's when you are breathing as often and as deeply as you can. You can probably only do this for about 10 seconds, and then you start feeling dizzy and you want to stop. And so then you have to multiply that out times 6 if you do 10 seconds. Respiratory rate normally is about 12 to 20 breaths per minute. Okay, so let's take a look at the alveolar gases. Of course, we're breathing air to make sure that we get enough oxygen into our blood, and we want to get rid of a waste product, CO2. So you can see here at a normal ventilation and that is alveolar ventilation of 4.2 liters per minute. You can see right here, so normal ventilation, alveolar ventilation, that is here, alveolar ventilation. You can see that the partial pressure of oxygen increases as it should, and the partial pressure of CO2 decreases as it should. And we should have, with a normal alveolar ventilation, we should have a partial pressure of CO2 in the alveoli of about 40 millimeters of the mercury, and we should have a partial pressure of oxygen of about 100 millimeters of the mercury, and those numbers will be important for the second section of this lecture. So 40 millimeters of the mercury for partial pressure of CO2, and 100 millimeters of the mercury for partial pressure of oxygen. That is at a normal alveolar ventilation rate. So here will be bronchial diameter as mediated primarily by CO2 levels in the exhaled air. That's not that important for you guys, how the local control of arterioles and bronchioles by oxygen and carbon dioxide works. So I'm just kind of skip over this. And we have our last slide for the first part here, ventilation. You can usually, when you go to a doctor's office, especially if you complain about breathing issues, then they will put a stethoscope on the back of your chest and kind of listen to your breathing. That would be auscultation as a diagnostic technique, and they're trying to listen to whether there's some sort of obstruction or some turbulence in the flow of the air. And then obstructive lung disease is when there is some obstruction. It's fairly common to have obstruction. Very common reasons for obstructive lung disease would be asthma. That means you have inflammation due to usually some allergic reactions. Maybe pollen can bring it on, or for some other reasons your immune system is kicking in and you have inflammation going on in your airways and it narrows it, and that's obstructive lung disease. Some people also have obstructive sleep apnea. There could be that your tongue rolls back and kind of obstructs your airways. That would be obstructive sleep apnea. Emphysema and chronic bronchitis, these are all sort of reasons why you might have obstructive lung disease that makes it harder to especially breathe out. Now, COPD or chronic obstructive pulmonary disease, that would be a combination of emphysema and chronic bronchitis. With emphysema being a condition where the air sacs are damaged, and this can happen easily through smoking or vaping stuff. And then chronic bronchitis, that's an inflammatory process that narrows the airways. So that concludes our first part of this lecture. I'm going to move right on into the actual gas exchange and transport of gases, and that will be chapter 18 in your textbook. And in this chapter, you're going to learn about gas exchange in the lungs and the tissues, how the gas are transported in the blood, and the regulation of ventilation. So here would be the pulmonary gas exchange and transport. So at the level of the lungs, you want to get oxygen into the blood and get rid of CO2 as a waste product. At the level of the tissues here, you want to deliver the oxygen into the tissues and pick up the trash and move that into the blood. So that's the essence of this slide right here. So let's take a look at this table here real quickly. It's a classification of hypoxias. And here's the first term, hypoxia is due to usually high altitude. There's a smaller amount of oxygen in the air that you breathe as usual. And anemic hypoxia, that's fairly common, that you have a decreased amount of oxygen bound to hemoglobin, and that is usually due to blood loss or for whatever other reason you don't have enough red blood cells. The other ones we don't really need to know. Surprisingly, the most sensitive sensors that you have for these different gases actually revolves around carbon dioxide and pH. And your body is very concerned about carbon dioxide levels, and because that's the reason for that is it's because carbon dioxide regulates pH. Most of you probably would have guessed that oxygen is our most sensitive sensor, but it turns out that carbon dioxide levels are much more carefully monitored, and because they are indirectly regulating pH levels. So the equation that you need to know, and I've put this up a few times, is that CO2 plus water creates carbonic acid, H2CO3, and that dissociates into hydrogen ions, and of course that is your pH right here, affecting the pH, plus HCO3 minus bicarbonate ions. So that is how carbon dioxide regulates pH or influences pH, blood pH that is. So the more carbon dioxide that's being picked up, the more acidifying of an effect it has on the blood. Now, oxygen levels, of course, that's important overall too, and it is monitored as well, but for some reason, or for a good reason, the carbon dioxide levels and pH levels are much more carefully or more sensitively monitored. So here would be the normal blood values in this table. The partial pressure of oxygen should be somewhere about 95 millimeters of the mercury on the arterial side, about 40 millimeters of the mercury on the venous side. The CO2 levels, 40 millimeters of the mercury on the arterial side, 46 millimeters of the mercury on the venous side as you're picking up more and more CO2. Now the pH, as you're picking up more and more CO2, your pH drops from 7.4 average to 7.37, and that's actually pretty low. You might think, well, big deal, it's not a big difference. Yes, it is. So 7.37, that's already a big difference, and is definitely very carefully monitored. So here is a review of the partial pressure of the gases of interest, which would be CO2 and oxygen. And so in the air that we inhale, we have about 160 millimeters of the mercury of partial pressure of oxygen and 0.25 partial pressure of CO2. So these are the numbers that are important. In the alveoli, the partial pressure of oxygen is about 100 millimeters of the mercury, and CO2 is 40. In the tissues, these are the numbers that are important. The partial pressure of oxygen drops down to about 40 millimeters of the mercury, and the partial pressure of CO2 increases to 46. So in other words, the partial pressure of oxygen oscillates between 100 in the alveoli to 40 in the tissues, and the partial pressure of CO2 oscillates or goes back and forth between 40 millimeters of mercury in the alveoli and 46 in the tissues. And the summary of these numbers is right here for oxygen and for CO2. Now this figure here summarizes some of the factors that are influencing alveolar gas exchange, and you can take a look at these. A lot of them are physical things like lung compliance, airway resistance, physical barrier resistance, thickness, and such things. So causes of a low alveolar partial pressure of oxygen. Of course, if you are in high altitude and you are the air that you're breathing has abnormally low oxygen content, that would be a cause of low alveolar partial pressure of oxygen. Also, it could be that the alveolar ventilation is inadequate, and it could be that you have decreased lung compliance or increased airway resistance, or there could be some sort of a CNS depression, meaning that alcohol poisoning, for example, you overdid it, binge drinking, passed out, and basically you shut down your central nervous system, or almost shut it down. So that could lead to you stop breathing, basically. Also, drugs can do that, especially opioids, and they're notorious for doing that. So an opioid overdose, it will lead to CNS depression, and that can cause you to stop breathing. So here would be how the gas exchange or diffusion barriers that we talked about earlier. So we're talking here about the diffusion distance between the single layer of epithelial cells in the alveoli. Then you have a single epithelial layer of cells lining the capillary, and then you need to go into a red blood cell. So you have a relatively small diffusion distance there, and that's what you need. So here, the diffusion across these two layers of epithelium, oxygen needs to go into the plasma first and then into the red blood cells, and then the CO2 needs to go from the plasma into the alveoli to be breathed out. So a big thing here is we need to talk about diffusion and solubility. So how much gas can you diffuse in a liquid? And the answer is not much. So as the oxygen enters the plasma and the CO2 leaves the plasma, how much gas can actually be exchanged? And for CO2, since the numbers are already relatively low compared to oxygen, the diffusion into a liquid, the plasma, that might work. But for oxygen, and especially given the oxygen needs of our cells, the solubility of a gas in a liquid, the plasma, is not going to be enough. And so here are some factors that are affecting how much gas you can diffuse in a liquid. And so it remembers, of course, the diffusion is dependent on the surface area, membrane thickness, diffusion distance is a big thing. The concentration gradient, of course, makes a difference too. How steep is the concentration gradient? Now, let's take a look at some pathological changes. Gas exchange is just going to be limited if you have any of these: decrease in amount of alveolar surface area, such as in emphysema, where you have damage to the alveoli, maybe due to vaping or due to cigarette smoking, something that you should really not do, by the way. Cigarette smoking, vaping is no good. Also, increase in the thickness of the alveolar membrane, such as in fibrotic lung disease, that would limit gas exchange. And then also increase in the diffusion distance between the alveoli and the blood, that would be a pulmonary edema. All of this would make it more difficult for gas exchange to occur. So here are some examples. Normal lung. Everything looks good right here in the normal lung. Now let's compare this to emphysema. In this case, the alveoli have less surface area for gas exchange, and that will limit the gas exchange. Fibrotic lung disease, here you have a thickening of the alveolar membrane, and that makes it more difficult for gas exchange to occur. In pulmonary edema, you have water that's building up right here, and that increases the interstitial space and the diffusion distance, of course, so increased diffusion distance. Finally, here in asthma, you have the airways are constricted, and that makes it more difficult for gas